I do now is something very simple called as urinary catheterization. Okay, now I mean, how all of you have catheterized, huh? And do you think that it's a simple procedure? In fact, it's one of the most important procedures that we do in intensive care. In fact, this procedure is done more than any other procedure in intensive care. Police catheterization. It is done more than any other procedure in intensive care, and all said and done, it has to be done extremely cautiously. Extremely cautiously, it has to be done with extreme caution and extreme care because the problems that arise out of a catheter-associated urinary tract infection are extremely problematic. So when you say catheter, it basically means a urinary catheter is any tube system that is placed in the body to drain and collect urine from the bladder. So what do you know about the catheter systems that you know? What are the catheter systems that you know?
Urine catheter.
What are the roots?
Roots.
What are the terminologies you know about a catheter that's there inside the body? So, go ahead.
Urine catheter is.
What is this urine catheter called? What exactly is this urine catheter called? When you're doing catheterization inside the ICU, what are they called as? No, that's the name of the device.
Urinary catheter.
No, it's called as indwelling catheter.
Indwelling catheter.
It is called as an indwelling catheter. It's very important to know that it's called what? An indwelling catheter. Why is it important to know that it is an indwelling catheter? Because CAUTI is diagnosed in an indwelling catheter. You understand? When you say catheter-associated urinary tract infection, the definition is based on a indwelling catheter. Unlike other catheters which are in and out catheters. For example, you have this in and out catheters, that means a straight catheter that goes in and comes out. That is called intermittent catheterization. What is that called as? Intermittent. Now you have indwelling, you have intermittent. Okay, clear on this? Indwelling and intermittent. You have another set called as external catheter. Now what is the external catheter? No, the external catheter is a condom catheter, where you have not breached the mucosa, you have not gone in at all. That is called as a condom catheter or an external catheter. An external catheter, okay? I think you should listen, okay? That doesn't make any sense to you. Okay? So external catheter. So the external catheter, you will understand, will probably have a lesser amount of infection as compared to an indwelling catheter. Okay? It's very clear that a condom catheter will probably have lesser amount of infection. There are various variations of each of these devices. Many manufacturers give various kind of devices that are there in place. There are various materials that you use to actually form these devices. For example, an indwelling catheter itself will actually have materials like latex, will have materials like silicone, will have materials like silver alloy, will have materials like silver impregnation, will have materials like gold. There are so many materials that can actually have these catheters, of which you must know one particular type called as a hydrophilic catheter. What is a hydrophilic catheter? Now, hydrophilic catheter is what? So why is urinary sepsis very easy to treat?
Because your outlet.
It's just going out. I mean, any drain in any pus in your body will work. You'll do well when it gets drained. No. So urinary catheter, because alright, is all getting drained. By definition, it is all getting drained. Yeah. You're okay?
Okay, sir. Continue.
So urinary catheter, samjha na? So now hydrophilic catheter. Now your mucosa doesn't allow bacteria to get stuck because it's very slippery. So similarly, when you have a catheter that that got a material coated on it, which actually is hydrophilic, it will make the catheter slippery, so bacteria cannot gain entry or touch the catheter and go in. That's called hydrophilic catheters. What does silicone catheters do? It is not different from your usual Foley's catheter. The material is different, that it prevents encrustation. That's all that it does. It doesn't change infection. It just prevents encrustation, crust formation. It prevents encrustation. That is all that a silicone catheter does. Alright. So these are the various catheters that we talked about. You have intermittent catheterization, condom catheters, and indwelling catheters. Suprapubic catheter is another form of catheter. It doesn't change anything. It is for patients who have bladder outlet obstruction, and that's why you give suprapubic catheters. Okay. So an indwelling catheter is the one that is left in place in the bladder. It may be short term or it can be long term. A newer type of catheter valve is, there are newer type of catheters which are valves which are open and then it drains into the circuit. The insertion can be either through the urethra or it could be suprapubic. Okay, and there is a small balloon that is inflated to prevent the catheter from sliding out of the body. Right? Huh? So what is a condom catheter? It's a condom-like device that is placed on the penis. A tube leads to this device into the drainage tract. It can't be given to which patients, Arshad? Which patients cannot get a condom catheter? Which patients do you think cannot get a condom catheter?
Urethral, complete urethral stenosis.
Obstruction. So if there is urethral obstruction, if there is acute retention of urine, if there is a person with bladder outlet obstruction, if there is a problem with patient who cannot void because of bladder dysfunction, there you can't use condom catheter. It is by definition you can't use it because it's not. It needs the person to actually pass urine on his own. So it can't be used in those people. What are the problems with the condom catheter you feel, Sachin?
So necrosis of the penis.
So it is said that there may be an increased amount of necrosis, but that's probably not very evidence based, because guidelines mention that there are no differences between those patients who've got condom catheters versus those who don't have, who are put in dwelling catheters. The incidence of maceration of the skin is not very high. That is a problem of defective nursing care, not a problem of the catheter. It's a problem of the defective nursing care or doctor supervision. You understand? So if you were to actually see, you put up a condom catheter and then subsequently you remove it and see how it is and then reinsert it, there is not going to be any maceration. As simple as that. Okay? Sorry?
We have to change it every day.
That is what is mentioned. We have to change it every day. Okay, so you may have to change the condom catheter on a daily basis. Clear on this? So the chances of what you said is probably confounded. It's not there. Okay, it's not there. It's the problem of the nursing care or the doctor's care supervision on this. Okay. Now, intermittent short-term catheterization are for those patients who basically have got postcoital residual urine, and they don't have the urge, or the bladder does not contract very well to remove all the urine. So in those cases, they do self-catheterization. Okay, self-catheterization is what they do. The process of self-catheterization is at intervals they catheterize themselves. They sometimes do not feel the bladder. For example, spinal cord injury patients. Intermittent self-catheterization is done. Okay, CIVC is done. Intermittent self-catheterization is what they do. It's basically to completely empty the bladder. That's the reason they want to do it. They want to completely empty the bladder so that you can prevent further bladder or kidney damage and prevent a urinary tract infection. Clear? So this is intermittent catheterization. So it is done by self. It is done by the own person himself. It doesn't need anybody there to do it. The person does it on the own only for all these purposes. Clear? Intermittent catheterization. So you might wonder, intermittent catheterization means you'll have to do a lot of aseptic precautions, that or betadine basis scrub karega like the VR wave scrubbing. But you will be surprised to know that there is no study that has actually said that an antiseptic solution like betadine versus soap and water or clean water will actually make a difference in infection rate. Okay, you understand what I'm saying? That is why when they're doing intermittent catheterization at home, they don't really go ahead and clean with betadine and do all these things. They just clean with water and they just pass the catheter inside. You're understanding? So it is not necessary that you need to have. However, the IDSA does mention that when you're doing indwelling catheters, you need to actually follow strict aseptic precautions and use an appropriate antiseptic solution. They say that. However, the evidence of that is very, very weak. Clear? So catheter materials, they are more often made of latex. That's the reason that whenever you're actually putting in the catheter, you should be asking them about latex allergy. It can be quite disastrous if the patient has got latex allergy, and that can be a problem. So whenever you're actually going to approach a patient for catheterization, what are the steps you will follow? Sachin?
So first of all, I'll let patient know, okay, we are going to catheterize you.
So they will never understand what is catheterization.
So, in the way and they understand like क्या होता है.
No. The first thing will always say what your problem is. You'll always say that the situation is such that we need to monitor your urine output, or you have got acute retention of urine and we need to take that water out, the urine out. Or you'll say that we need to see what your urine output is and figure out what it is. That is the first thing you'll say. Why? Then
how?
Means what? What will you say?
So how are we going to do like?
It's very important to tell the patient that it is going to be slightly uncomfortable. It cannot be comforting. It is going to be slightly irritable. It should be. It is going to be highly. It is going to be less comforting. It's going to be uncomfortable, isn't it? You're going to say it's going to be slightly uncomfortable, and I'll try to help to make it as minimum as possible. Right? What will that do?
That will make it cooperative.
That will allay the anxiety, and that will keep high cooperation along with that particular patient. Then, how do you proceed for catheterization?
Then the procedure will do.
What's the procedure?
With another septic condition, like I'll first of all I clean him the
First, patient privacy.
Yeah,
Okay,
privacy.
the first thing is always patient privacy.
Patient privacy.
Simple details, very important details. Patient privacy. If it's a female chaperone, okay, it's very clear. If there's a female, it's a chaperone. Similarly, if it's a female catching a male, there's a chaperone. They can't do it on their own. Chaperone means a person is going to sit beside this particular person. Right? Go ahead then. Do you require consent?
Consent we don't.
We don't. So in the police catheter, we generally don't require consent. Then
We'll start with the procedure with the condition and
how do you do the procedure?
first of all we'll see like the area is clean or not first. Like, if it is a hair nostril, we will remove the hair.
You don't need to remove the hair.
We don't.
No, never. So that's why I want to know what you do. You never remove the hair. Go ahead.
So
You never remove the pubic hair, you never shave it because shaving causes more amount of problems, causes infection. You don't do that. Go ahead.
then I'll clean the area from inside out.
How?
From inside out.
So normally what you need to do is you need to first prepare your set. You need to prepare your set. Your set involves what all? Your set involves the fact that you get a Foley's catheterization kit. If you don't have a kit, the set that the nurse prepares. The set that nurse prepares has got a kidney tray, you should have a 20cc syringe, you should have new lignocaine jelly, you should have either distilled water or normal saline that is present, you should have 2 pairs of sterile gloves, and you should have at least 10 pairs of 10 gauze pieces. Okay, the first thing that you will do is probably have a second operator in front of you, along with the number of Foley's catheters that you require, which is average 14 to 16. Right? Clear? Clear on this? This has to be ready. And adequate lighting is very important. Adequate lighting. Only then you are good. You have to be professionally sound. So when you give a UK exam, for example the PLAB, or you give any of the European exams, you know the OSCEs that they have. The OSCEs that they have all this in place. Okay, they have all these things in place. The Australian exams, they have this in place. So if you miss out any privacy, miss out anything like that, you're out. That is why this is very important to get it in your mind. You are expecting the nurse to do stuff. What if the nurse forgets? What if the nurse makes it? It has to be you. You are doing. You are the operator. You are supposed to keep things ready. Right? Okay. Then what do you do after that? Then the next thing that you do usually is you take the gauze pieces. You first sterile wash yourself. Wear sterile gloves. Let the operator open the table for you. Open the set for you. Take the gauze pieces. Keep it in your fingers so that it is professionally done. Keep it in your fingers. 1, 2, 3, 4. So 4 you can hold. 4, you're going to hold 4. 1, 2, 3, 4 and 5 in your hand you're going to hold. 6th is going to be on the sponge holder. The 6th is going to be on the sponge holding forceps. Right? So you have 6 gauze pieces that you're going to hold at one stage. Then you will probably use what solution?
Betadine.
No, you use always betadine. Don't try to use the alcohol solution because there might be problems. There might be, if it's cut or if it's painful, it may become very painful. Mucosa never used on alcohol. Okay, alcohol never used on mucosa. So you use probably betadine. Okay, antiseptic. That is the antiseptic that we are using in our hospital. Betadine solution. So when you use betadine solution, you actually are first ensuring that betadine is on that gauze piece, and then you're cleaning inside out. 1 gauze piece, 2 gauze piece, 3 gauze pieces. 4th gauze piece also goes by. Then you're going to clean inside out. The 5th gauze piece is actually, the 4th gauze piece is actually used to clean the meatus. After cleaning the meatus, then you throw that gauze piece down. The 6th gauze piece is for holding the penis. So leave the 6th gauze piece there. Put up a whole towel onto this particular patient, and when you're cleaning from the knee up to the umbilicus. From the knee up to the umbilicus. You're not cleaning anywhere midway. From the knee up to the umbilicus. It has to go up to the knee and up to the umbilicus. Okay, then what do you do? What is the next step you shall do?
So then we'll hold the penis, withdraw the
prepuce,
and we'll put lignocaine jelly, the whole of the lignocaine.
So what is the dose? How much lignocaine jelly do you use? So you are female, you are male. It has to be different because urethral size is different. How much is it? Elizabeth?
20 cc for male patients and 4 to 5 cc.
No, that's not the answer. What is the answer? Anyone? So the recommended amount for a female is 3 to 5 ml. Okay, the recommended amount for a female is 3 to 5 ml of jelly. 3 to 5 ml of jelly. Right? And the recommended amount for a male to begin with is first 15 ml. Okay, the first amount is 15 ml, which corresponds to how much milligrams? How much? 20 milligrams is 1 ml, right? 20 milligrams is 1 ml. So how much milligrams is it? 300 milligrams. You want to say give me 300 milligrams of lignocaine. Okay, 2% lignocaine. Right? And then that 15 ml goes inside. Right? And after that, what do? You wait for some time, 3 to 5 minutes. Then what do? This 15 ml, it can be 10, it can be 15. Why am I saying it can be 10, it can be 15? When it reaches 10, patient might say, I'm feeling full. I'm feeling full. Okay, but that is not the capacity of the urethra. The capacity of the urethra is 30 ml. The capacity of the urethra is 30 ml. So once 15 ml goes inside or 10 ml goes inside, patient might say it's tight ho gaya hai. Then you wait. Okay, and then after that you put another 15 ml. 2-3 minutes later, you put another 15 ml. That is when you say that probably the urethra is going to be anesthetized. Clear? That is when you say the urethra 600 milligrams of lignocaine goes inside. That makes it clear that the urethra is anesthetized. Then after 2 or 3 minutes, then you pass the catheter with a no-touch technique. That means somebody, second operator again opens up the Foley's catheter, gives it in your hand. After he gives it in your hand, the next step you do is you give it back to him and he'll open up. So it's called as a no-touch technique. Okay, in the no-touch technique, the sleeve, the plastic sleeve that is there in the Foley's catheter, you use that to actually insert the catheter. Once you go inside, at any given moment, if there is any kind of resistance, you are not supposed to go in. At any given moment, if there is resistance, you are not supposed to go in. You go in, and after you reach inside, if there is expression of urine, what do you do next? If there is expression of urine, what do you do next? Once urine comes in, no, you put the catheter more inside. Okay, if once you get urine, you are certain that you are now in. But now where are you? We don't know where you are. Literally the roof of the bladder. You have to get out, right? So then what do? You pass it more in till you come to the bifurcation. Till the whole catheter goes up to the bifurcation. Okay. Once it reaches the bifurcation, that is when you will decide to put in water. Okay. How much water do you use, Ashok?
20.
The conventional rate is 10 ml. Conventional it is 10 ml. So all of you are not really catheterizing like the way it's supposed to be catheterized. Conventionally it is 10 ml. However, you can actually figure out on the Foley's catheter how much you need to inflate. You don't need to inflate the whole thing. On the catheter it's written 10, 15, 20, 30, 35, 40. It's written all those. That is the capacity, but you don't need that whole capacity. The balloon that is the balloon capacity. 15 ml, 20 ml. That is the balloon capacity. You're understanding? But you don't need the whole capacity. You may require 15 ml, 10 ml, but actually it is only 10 ml. 10 ml is all that is required to actually inflate and keep the bladder. You inflate more than that, the bladder will float up more higher, it will keep irritating the bladder. Clear? Clear on this? After this, what do you do? What is the next step, procedure after this? After you've inflated, what do you do next? Connect it to the urinary catheter bag, the system. You connect to the system and keep the system below the pelvis at any given moment. And then what do you do? And then what you do is you fix this particular device, fix this particular Foley's catheter to the thigh so that it prevents movements. Okay, this is what all this is about. Clear? Okay, the size of the catheter is always in French units, and that's why when we talk about French units, it's 14 to 16 French catheters appropriate to most adult women. Okay, so this is what the catheter is about. You have a Foley's catheter, and sometimes you have a triple lumen catheter which is used for bladder irrigation. You sometimes say triple lumen catheter, and then there's a straight catheter which is used for a one-time basis to obtain a urine sample. So what are the indications of a urinary catheterization? Whenever there is incontinence, whenever you want to chart the intake and output, whenever there is a high risk patient in which you could monitor their urine outputs, whenever there is acute retention of urine, which is an absolute indication, bladder outlet obstruction, an absolute indication, then spinal cord injury, dementia, and for palliative care. So these are few places where you use a catheter. The indications are very clear. For a post-op patient that comes in for surgery, after large major surgery, it's very essential to get rid of the catheter within the second or third day. It's very essential to get rid of the catheter within the second or third day because there is no indication for the catheter. There is really no indication after the second or third day of the major surgery that undergoes for monitoring purposes in the ICU. So urethral injury. This is one of the place where you will not do anything. If there is blood in the meatus, you will not do anything. If there is blood on the meatus, you don't touch it. Don't try to do anything. If there is blood on the meatus, just leave it there. Call the urosurgeon. You are not supposed to go and instrument any time if there is blood on the meatus. Very important. Urethral injury. Okay. Because at this stage, one of the prime reasons for urethral, especially after trauma, is a pelvis injury. And a pelvis injury will cause the prostate to be high riding. And in that case, if you were to actually pass in the catheter, you might injure inside. समझ में आ रहा है? Huh? So in a trauma case, if you get blood on the meatus, you are thinking of a prostatic injury or a high rising prostate, which is also called as high riding prostate, which is sine qua non for a urethral injury. So you don't try to do these things in trauma cases the moment you get blood on the urethral meatus. Okay, so this is what you normally you get is what we already discussed. Very important, ensuring privacy, explaining the procedure to the patient, possible complications and specific concerns that need to be addressed. Supine in a lithotomy position, the legs apart and feet together can also be done. No touch techniques, sterile gloves, gauze and forceps, squeeze sterile lubricant, identify urethra in case of nail hole penis with the left hand. That's how it is. Okay. Insert 15 to 30 cc saline to fill the balloon. Usually it's 10 cc is all that is required. Partially filled balloons may lead to catheter displacement urethral bladder trauma. Clear? Huh? So cleansing the urethral area. So when the catheter itself, soap and water. This is what they do. What do the nurses do? They do actually a soap water. With soap and water they actually clean after every bowel motion and also. So it's very wrong to actually have a catheter in place and bowel motion to have undergone and you have not done anything. It's very, very, very wrong. Okay, that you have. Why? Because the way a catheter infection develops is based on that. A urinary catheter infection, which you call as CAUTI, catheter associated urinary tract infection develops, is the same way. I will explain to you how it comes. Every day, when you have got fasted BID, I is there in that. Okay, that every day, what are you thinking? What do I do with the catheter? Do I take it out? That is your first thing. Can I take the catheter out? Can I take the catheter out? That should be your first thing. Because every day that the catheter is in place, there is a 1 to 3% chance of a bacteria getting colonized. Colonization will lead to infection in patients who have a problem. Clear? Huh? So every single day of catheter, there is a 1 to 3% chance that the catheter gets colonized. Right? Clear on this? Aspirate, as you already know, we all know, aspirate the balloon before you take this catheter out and ensure that there is no soiling that is occurring. Okay, what do you do in these cases? Okay, if the patient is having no urine output coming from the bladder, from the urine, the first thing you have to do is not go and give fluid more. If there is no urine coming from the bladder, after you put it in Foley's catheter 3-4 days, 3-4 hours later you see there is no urine, the first thing you do is do an ultrasound. Okay, you figure out whether the ultrasound has got urine or not on the ultrasound. If the ultrasound shows that there is a bladder, obviously the problem is the catheter. So you probably may need to either flush or remove the catheter. Freshly placed catheter you may still flush, but if it's a catheter that has been for a while, it is essential to change the catheter. Okay, changing the catheter. Okay, the trauma. In the event that there is a trauma, when you are inserting the catheter, abandon the procedure. Abandon the procedure immediately and call a urosurgeon. Don't try to go ahead and do things with that. Huh? Yeah. Now let's go to associated urinary tract infection. So what do you understand by CAUTI, Nikhil? What comes to your mind when I say CAUTI? When I say CAUTI, what comes to your mind? Let's take. I'm just putting this word CAUTI. Okay. And now, what is coming to your mind? Come, write. What is coming to your mind? You can write one word that comes to your mind. When you say CAUTI. Sepsis. Supriya, you can write one word that comes to your mind. You can write it. Evidence of fever.
Episode of fever.
Episode of fever. Okay. Chandrima. Go write something quickly. Quickly, come on. And next, you're going to write. Huh? You just want to see what you want to say CAUTI. Aseptic precaution. Okay. So we had Nikhil saying sepsis, we had Supriya saying episode of fever.
Most common in immunocompromised or
Immunocompromised fever.
Comorbidities.
Immunocompromised comorbidities, you can write comorbidities. And which are the comorbidities you want to write? You can write it down. So she feels comorbidities and you can write down. Okay. Ashok?
Catheterized patient with suprapubic tenderness.
With suprapubic tenderness, okay. Okay. What about Sachin? So all of us have actually written a lot of things together, which makes a lot of sense. All of us, none of you are wrong. Okay, about what you have written. All of us have written the right things only. That we can think about CAUTI. So first of all, the definition. What is the importance of CAUTI in the Indian scenario? See, first of all, which is the most this is almost 30% of the hospital-acquired infections. Among all infections that you think of, that is acquired from the hospital, which includes hospital-acquired pneumonia, which includes ventilator-associated pneumonia, which includes central line-associated bloodstream infections, which includes any infections. There is skin and soft tissue infection coming from a drain. The 30% of the entire ball game is actually catheter-associated urinary tract infection, and in that 30%, 75% is because of indwelling catheter. 75% is because of indwelling catheter. Clear? Now, importantly, abroad, the incidence of catheter-associated urinary tract infection is 6.6 per 1,000 catheter days. How much is it? 6.6 is 3.3, sorry, per 1,000 catheter days. Okay. Now, in Asia, the risk is directly 6.6, double. In Asia, the risk is double. And this from where we got? This we got from a study that we were also a part of called as the INIC database. There is a live database going on. Any one of y'all can go onto the website and see INIC. Okay, International Noso Consortium of Infectious Diseases करके there is a database by Victor Rosenthal from Argentina, and in that database you will actually figure out what is happening. Okay, so we also contributed data for this at a while. Now we stopped doing that, but various countries across the world is actually contributing data to figure out what is the figure. So what they'll find is that the Western population have got a CAUTI rate of 3.3%, whereas we have a CAUTI rate of 6.6%, Asian population. So that means to say we will have more and more incidences of catheter-associated urinary tract infection. And since we are in a developing world, we see more and more patients living longer and thus requiring more amount of care, of which one is indwelling catheters. Right? So we have definitely a problem. Much higher than that of the Western civilization, and we know that this particular catheter-associated infection can increase the healthcare cost, length of stay, morbidity. All right, clear on this? Clear? So first of all, one thing that I wanted you to write was nosocomial. It was very important for us to write it as nosocomial because it is not an infection that was present at the time that the patient came in. It has developed later on. Right? It has developed later on. And that is why when you have to diagnose a case of CAUTI, it's very different from urosepsis. So how to diagnose a case of CAUTI? Supriya, say for example you want to diagnose a case of catheter-associated urinary tract infection. How do you diagnose it?
Anything like so presence of sepsis after 48 hours of catheterization.
So you said one right term, after 48 hours. Okay? After 48 hours. What else? Chandrima?
Presence of organisms after 48 hours.
No. It's very specific definition. So, anybody?
Patient with complaints of fever, burning micturations after the 48 hours of catheterization.
Previously,
So that is the biggest problem. So when you have a patient on a catheter, it's very different from that when you have a patient without a catheter. Now, without a catheter, a person will talk about dysuria, frequency, urgency, pain, burning, all this. You have a catheter in place. Once a catheter in place, the only two signs that you'll probably get is suprapubic tenderness, and the other one is
Fever.
no.
Renal
Renal angle tenderness. Very non-specific, isn't it? So when you are saying CAUTI, the two specific things that might come into your mind has to be a suprapubic tenderness and the presence of a renal angle or costovertebral tenderness, right? Renal angle tenderness. Clear on this? There are two things that come to your mind whenever a person is coming with CAUTI, right? So when you diagnose CAUTI, you should have the presence of a catheter. Okay, now there are two things in the definition. First, in the presence of a catheter that has been in place for more than 48 hours. That is the first thing. Or the catheter has just been removed 1 day prior. Or if the catheter is removed 1 day prior. So the catheter was there for 5 days. 6th day I removed the catheter. 7th day patient had fever. Clear? That will also be part of the timing. That will also be the timing that you are looking at. Clear? That is one aspect of the story. So you should have the presence of a catheter, or the catheter has just to be removed and next day you develop signs of infection or sepsis. Clear? The second criteria is, if the presence of a catheter, you should have at least a suprapubic tenderness, or you should have some feature of sepsis, or you should have a renal or costovertebral angle tenderness in this case, when you have a catheter. Or when you don't have a catheter, you will have the feelings of urgency, dysuria that is occurring because the catheter is no longer there. That is still counted as catheter associated urinary tract infection. That is the second. Whereas the third, which has to be there along with this, is the presence of a microbiological criteria. A microbiological criteria where you should have not more than 2 organisms. Not more than 2 organisms, of which at least one organism should have a colony forming unit of more than 10 raised to 5 CFU per ml. 10 raised to 5 CFU per ml. Clear? So let's go back to the definition. So what is the definition of CAUTI now? The definition of CAUTI will involve you to have a catheter that is in place for the last 48 hours, or it has just been removed 1 day prior after being there for more than 48 hours. Okay. The second thing is, if it has been removed, then the urgency, frequency, all that should be there with accompanying signs of infection. Whereas if there is the catheter in place, you should have suprapubic tenderness or renal costovertebral angle tenderness. And the last is the presence of a microbiological criteria which says that you should have not more than 2 organisms, of which at least one organism should have more than 10 raised to 5 colony forming units per ml. Clear? And these organisms can't be fungus, can't be parasite, can't be mold, can't be candida. It can't be those. समझ में आ रहा है? It can't be candida, it can't be mold, it can't be parasites, can't be all this funguses and all. Clear? It has to be a bacteria. Clear? Understood? Now when we started talking about catheter urinary tract infection, we also said that every day that the catheter is in place, there is a 1 to 3% chance of the catheter getting colonized. This means to say, at the end of 2 days, every one of us will have some colonization, although not if we are catheterized. Right? The chances of catheter after 5 or 7 days are very high. Right? That being colonized. Clear on this? This means to say, today if I have a patient on a catheter and I take a urine sample and send it, I will get some bacteria. Why won't I get a bacteria? I will get a bacteria. Are you understanding? But that is not related to catheter associated urinary tract infection, because there are no other no other signs that you are probably getting. Plus, there may be another source for which the patient has come. It is a very big mistake for you to send a urine sample for culture in a patient who has got an indwelling catheter unless you have not done a complete investigation and have found out that there is no other source of infection in a person who is either immunocompromised or is demented. Are you understanding? Clear? So you cannot send, because I have an infection, I have a fever. Because I have a fever, I am going to send urine culture. That is wrong. That is completely baseless. Clear? Why? Because you will get something. and if you get something, you will start treating. You understand? So can fever come into this? You understand? No, fever cannot come into this. Clear? Huh? Clear on this? Huh? So which are the routes which the catheter enters inside? The catheter usually enters inside from few routes. The first route is actually extraluminal. That means the catheter gets colonized, the Foley's catheter outside gets colonized, and then from there it enters into the lumen. Extraluminal. Okay, that means outside it is lying outside somewhere. It was touching the feces that I explained to you. The patient has just passed motion, and there is a large amount of bacteria that has now coated the Foley's catheter, and now the catheter is not clean, and now that goes upwards and ascends upwards. That goes up and ascends upwards. Clear? So it's coming from the external area. Extraluminal. The other is intraluminal. Now, when does intraluminal take place? Intraluminal takes place, for example, now you have a patient who is being moved from your ICU to the CT scanner, and then you decided to move this patient. During the movement of this patient, you actually lifted the Foley's catheter and kept it on the bed. Okay, you lifted the Foley's catheter and kept it on the bed. What is going to happen? The urine that is lying inside is now going to track upwards into the urinary bladder and cause a intraluminal ascending infection. Intraluminal ascending infection. Clear? That is why a bladder collection device should always be under the pelvis and not touching the floor. Under the pelvis and not touching the floor. Clear? Under the pelvis and not touching the floor. Clear? Clear on this? Okay. The third is hematogenous. That means there has been some bacteremia somewhere, and from there it has entered inside. But that is by definition not catheter associated UTI. It is a hematogenous spread. Clear on this? Clear on this? Any doubts till now?
Why we are considering only bacteria, like you said, not any other
Because we don't consider fungus to cause catheter associated urinary tract infections. We don't associate fungus with a catheter associated urinary tract infection. It's usually bacteria. So fungus usually will be there. Okay, so you will grow candida. That doesn't mean there is a urinary tract infection. Candidemia is something important. Candiduria is not supposed to be treated. Okay, candiduria is there. Today you do your urine, you probably get some fungus. Okay, clear on this? Clear? Now when we go ahead in catheter, so remember one thing, when you have catheters with urinary tract infection, there are two, whenever you consider urosepsis, there are two parts of urosepsis. One is urethritis cystitis and the other is ascending pyelonephritis. Okay, classically, urethritis and cystitis is a localized infection of the bladder. It is a localized infection of bladder. Okay, when you say ascending pyelonephritis is an infection that causes hemodynamic instability, fever, and admission to the ICU. So you can't have cystitis. Cystitis urethritis is also present with the same fever, will also present with the same amount of bacteria and all these things, but they are not dangerous. You understand? They are not something you be worried of. It is the ascending pyelonephritis that you will be worried of, because there you will probably have the kidney to be involved, and you may require interventions to get that out, to get it settled down. Clear? So you can't have a cystitis and urethritis. So that is why importance of an imaging. The importance of imaging comes there. So for example, if you are considering urosepsis in the ICU, you should be always thinking of what? You should be thinking of ascending pyelonephritis, pyonephrosis or something of the kidney. A urethritis and a bladder cystitis is not going to be the one that is making your patient so bad. Because by definition it doesn't cause so much. Very rarely it causes something inside. Are you understanding? Clear on this? So the symptomatology will actually relate to your imaging. That's why you should know to pick up a hydronephrosis. Though it is very difficult to do that, but it is very important to pick up a hydronephrosis as an intensive care doctor, because you know I have to now go to a higher form of imaging like CT scan. You understand? If you do not do that, if you cannot do a hydronephrosis, you will not know when to send for a CT scan. As simple as that. So you need to figure out hydronephrosis. Okay, hydronephrosis is something that you should need to figure out so that you can do a CT scan and direct a CT scan. Clear on this? Clear? On the imaging modality, you go to an imaging modality because you want to rule in or probably rule in other pathologies which is not related to the bladder. So you don't need a contrast CT scan for these patients. You need a plain CT. But when you are thinking of another pathology, for example, you are thinking of a pelvic abscess or maybe some kind of growth down there, then you need a contrast. Are you understanding? You don't need a contrast otherwise. You just need a plain CT scan to understand hydronephrosis. Clear? Huh? Clear on this? On the way I'm going to go ahead? Definition we are clear? You understood about how do you actually what microbiology you require? Huh? Okay, so how do you prevent this? So which are the patients who possibly will have CAUTI? So as you said rightly, the sex is very important first. The female sex has got a higher chance of having a catheter associated urinary tract infection. But as Vidya said, comorbidities of which diabetes forms a very important part. Elderly age group, very important part. These are those patients who probably will have catheter associated urinary tract infections. Clear? So the analysis. So normally what happens is you end up sending a urine. You end up sending urine. So you have done everything possible that you think of to rule out every other organ. You have seen everything. You have seen the bladder. You have seen the abdomen. You have seen everything, and you don't find anything else anywhere. The last thing you think of is CAUTI, not the first thing. What happens to you all, because it's easily done, is the first thing you'll think is CAUTI. You're understanding? So the last thing in my diagnosis GD would actually be CAUTI. Very last thing, very last thing. Clear on this? Because Sachin, what will happen if you send a routine Mexican culture?
So there will be some.
There will be some organs, and then you will see the organism and you will forget what you are supposed to do. What is the actual problem? You forget what is the actual problem. Okay, so coming to a urine study. Whenever there is a UTI, you do a urine study. What are you looking at the urine study, Elizabeth? What in that urine study are you looking at?
We look at the pulses.
So what the persons are looking at, Supriya?
So pulses normally can be present.
What is the number that you look at?
So 2 to 5 pulses.
What are the number of persons you require to call it as CAUTI?
About 10.
About 10.
So above 10. Okay. So usually when you're looking at catheter associated urinary tract infections, you will have pus cells more than 10. You will have more than 10 unless the patient is neutropenic. Unless the patient is grossly neutropenic. When the patient is grossly neutropenic or there is an obstructed urinary sample, you will probably not get that much amount of pus cells. Okay, so more than 10%. So more often than not, when I'm suspecting CAUTI, I should see pus cells to be more than 10. If I'm really thinking of CAUTI, once the pus cells is also low, then there is no reason to send for urinary tract infection if there is no neutropenia. You understand? There is no reason to send. That is why a freshly collected urinary sample. So how do you collect the urinary sample in a CAUTI specimen? Supriya, Vidya.
Correction.
How do you collect the urinary sample?
Collection.
Huh.
So in a sterile technique.
How?
If the patient is catheterized, then we can directly get it from the midstream sample we use.
How do you collect? I'm asking you simple. Theory nahi. Tell me, how do you collect?
From the bag.
No. So the answer is you never collect it from the bag, because if you collect it from the bag, you will get polymicrobial specimen. You will get hundreds of bacteria in that bag. If I take a urine sample and keep it here for next 30 minutes, after 30 minutes I will see proliferation of bacteria. The number of colony forming units will go up. Similarly, in a bag, if you leave it over there, if you collect it from the bag, there is going to be, this is completely wrong to do, to collect it from the bag. You will never collect it from the bag. So how do you collect it, Ashok?
So there is one port for collecting the sample.
Yeah.
So we clamp the pulleys and after that we'll insert needle.
So alcohol swab, clean the port, take a syringe, see the port. So today go and see the port, and you collect it from the port. Okay, collect it from the port, and then the processing has to be done within 30 minutes. You can't have the catheter you have collected and you have kept it on the side and then you're sending after 30 minutes, you will invariably grow something. You understand? You have to grow it immediately. You have to send it immediately for sampling, right? What else you are going to look at the urine, Nikhil or Ashok? What are you going to look at urine? Urine तुम देख रहे हो और क्या तुम्हारे urine का sample report तो बहुत बड़ा है. So what are you looking at? एक तो pus cells they said. What else?
Protein, urine color.
No.
Urine protein.
No. Color, smell, appearance, does not relate to urinary tract infection.
Cast.
You can't look at it and say, "Arey, ये तो पूरा pus है." ना? No.
Cast.
No. I mean talking UTI. Where casts and all will come when you are thinking of glomerulonephritis and things like that. What in the urine are you looking at which will help you with UTI?
Gravity.
Proteins.
No. No. So that means you aren't looking at urine samples. What else are you looking at?
बैक्टीरिया भी रहता है
Now, bacteria present will indicate what? Bacteria present. So he's saying something. Bacteria present. What will that indicate? It will indicate there is a presence of a bacteria, but that could be an asymptomatic bacteriuria also. The asymptomatic bacteriuria is when you send a urine sample without any inclination that there is CAUTI. You just send a urine sample, you find some bacteria in that. That is asymptomatic bacteriuria. You don't treat asymptomatic bacteriuria unless
Symptom.
solid चाहिए. You don't treat asymptomatic bacteria unless there are symptoms. Patient has no symptoms, that's why it's called asymptomatic bacteria. When do you treat it? When do you treat it?
more than 10 liters.
Huh?
10 is to 5, more than 10 is to 5.
It is going to be 10 to 5. When do you treat it? Asymptomatic bacteria is when there is going to be 10 to 5 colony forming units. It is going to be. There is bacteria, there is 10 to 5 colony forming units.
Recurrent.
When are you going to treat it?
Recurrent. It is recurrent.
No?
Modality.
No?
Presence of pus.
It's when you are pregnant. Number one. And second, when there is an oncological procedure or there is a urological procedure that is going to take place. For example, you have a patient who is having is admitted to the ward, going to undergo a TURP, or you have a patient in the ward who is undergoing a DJ stenting, or there is a person in the ward going to undergo some urethral reconstruction, and that time you do a urine routine microscopy. Urine microscopy shows bacteria. A culture shows 10 to 5 colony forming units. That is the patient in which you will treat. Asymptomatic bacteria. Patient has come for something else, but that's why urine routine is done. So you might see this. Very often a person is coming for something else, but there is a plan for a TURP, they do a urine routine. The urine routine is done for this purpose. And here, it is not the usual 3 or 5 days that you give the antibiotics. For you give the antibiotics 5 to 7 days. Clear? Pregnancy is a similar condition. Pregnant patients, when they come in for their first antenatal checkup, a urine routine is done. In their first antenatal checkup, the first antenatal checkup, when you do a urine, you did a urine routine. Why was it done? For this reason. You understand? Otherwise, why would you do a urine routine? The urine routine is done when you're pregnant, because on the first antenatal checkup, if there is bacteria in that, you give 7 days of antibiotics. It is supposed to be given. Clear? So that's the only case. Let's get back to the urine routine. What else are you going to give urine routine? Nitrite. There is a nitrite in that. You see in the urine routine there is something called nitrite. Next time please look at it. Okay, if you don't understand, look at it. Okay, nitrite will say positive or negative. Why nitrite positive means what?
Bacteria.
No. It means what? It means gram-negative organism. It means what? You understand? It means the presence of a gram-negative organism. Only then it will come out to be positive. And which gram-negative organism will not be positive? Pseudomonas. So tomorrow, when you grow Pseudomonas from your culture, and you find the nitrite to be negative, you should be thinking by SRQ, nitrite to be positive. You should be thinking that there is one more organism. It's not just Pseudomonas. Yes, understanding? Once more. Nitrite. Once there is nitrite, once there is the presence of nitrite, it indicates that there is a gram-negative organism, excepting Pseudomonas. Excepting Pseudomonas. Right? So now you do a urine culture, you find Pseudomonas. That means what? There is one more organism somewhere. We need to figure out where that is. Clear? In the realm of CAUTI, nitrite test. Clear? Simple test. It's a very simple test. You will do nitrite aa gaya, gram negative aa gaya, so isme gram negative cover good. That is how you start thinking. Are you understanding? You think like that. If it was already patient is on meropenem, for example, patient is on meropenem, you have done everything possible to find out the source of infection, and you find that the probable infection is in the urinary tract, and it is the CAUTI. I think it's the CAUTI because everything else is ruled out. It's only that. And he's been on meropenem for the last 4 days, and he develops a urinary tract infection. Okay, you do a nitrite test, it comes gram negative. Okay, and that is the source of infection. Probably the meropenem isn't working. I need something higher, I need something different. It will help me to change my antibiotics. Clear? Then what else you look at?
So, what if that is positive and there is no gram negative?
What is that? So gram negative. So it can be positive in asymptomatic bacteria also, no? It can be positive whenever there is gram negative organism. You are understanding? Whenever there is gram negative organism. समझ में आ रहा है? हाँ? But here my suspicion is positively towards CAUTI. I am looking at CAUTI. The whole picture is that of CAUTI, and that is what I am looking at. समझ में आ रहा है? हाँ? Because there are gram-positive infections also in the urinary tract, and which are those? Gram-positive. E. coli is gram-negative. E. coli, Pseudomonas, Klebsiella, Enterobacter. These are all gram-negative organisms. Okay. Gram-positive. Which are the infections that you see in the urinary tract?
Gonococcal.
Urinary tract in CAUTI, you will have two main organisms. Staph saprophyticus. Staph saprophyticus is what you will get, and the second gram-positive organism that you can get is Enterococcus. So there are two organisms that you will probably get in the urinary tract. Okay, you will get Staph saprophyticus, and the other will be Enterococcus. Clear? So in cases where you get a urine culture showing Enterococcus and the nitrite is negative, you are clear that this is a pure gram-positive infection and coming from the urinary tract. Clear on this? Staph saprophyticus and Enterococcus. Clear? Clear? Whereas the commonest that you normally get gram-negative is what is mentioned over here is E. coli. So I am very happy that you said E. coli, because gram-negative is the commonest organism that you will get inside the urinary tract is going to be E. coli. Not that you won't get the rest, but E. coli is something very common. Clear? Clear on this? Clear on this till now? Clear? What else in the urine you're going to look at? You're still in the urine routine, you're not gone more beyond it. What else in the urine?
So casts are not important.
What else in the urine? We are talking about UTI, no? In UTI, what else in the urine? Casts are in different diseases.
Sugars. Sugars.
No.
Usually high sugars.
So that is predisposing, but CAUTI, going towards a diagnosis of CAUTI is, diagnosis of CAUTI में क्या आएगा? No? There's something called pH, right? Urinary pH.
Acidic.
No, alkaline pH.
Alkaline pH.
So what is alkaline? Acidic is usual. Usually your urine is going to be acidic. But when it becomes alkaline, what are you looking at? You're looking at Proteus infection. When there is alkaline pH, you're looking at Proteus infection. Not anything else. Acidic is going to be always been acidic. Even normal UTI is going to be acidic. But if there is Proteus, there is a very high chance of having alkaline urinary pH. Clear? So in the event that I do my urine routine, I see my pH, I see my nitrite, I got already an idea that this is what is happening here. Are you understanding? Because I need to figure out which bug I should treat. That's why I'm looking at this. So from a simple urinary tract infection, urine routine microscopy, you can also do something called as a gram stain in that urine. Okay, which doesn't take more than 10 minutes. So if you are strongly suspecting of CAUTI, pick up the phone, call the microbiologist, say, Madam, I need to do a urine gram stain. Can you do it quickly and tell me? You understand? I have a nitrite that is negative. I have the presence of normal urinary pH. But I am strongly suspecting a UTI. Pus cells are 25. Gram stain करके मैडम gram positive है क्या देखो ना? Because commonest is E. coli, you might treat only gram negative when there is gram positive. समझ में आ रहा है? Are you understanding?
Yes.
So a simple urine routine microscopy can give you a large amount of picture into what is happening in a direction towards how to treat this urosepsis.
So specific gravity will not change.
It will not change, nothing will happen in specific gravity. So you are doing specific gravity for some other reasons, not for this reason actually. Not for this reason. Here we are looking at CAUTI. Okay, we are completely on CAUTI. Urine routine microscopy can be talked about for an hour. Okay, but now here we are talking, the topic of our discussion is CAUTI. So in CAUTI, this is what we're going to do. Are you clear on this? So that's why when a urine routine is sent, be after it, look at it, interpret it. Next time you don't need to think कि मैं exam के लिए पढ़ूंगा. Exam के लिए you are studying for life. You are studying for your entire life ahead. Don't consider this time that we are working over here for an exam. You are studying for life. You study for life, you get better. Okay, it's as simple. तुम लोग का future है. You understand? Exam pass होके तुम if you don't know how to work, obviously you will remain that way only for your entire life. That's how it is. So that's why I study for your life. Okay. So urine routine microscopy. Right. Then I will do a urine culture, which will actually tell me what is the existing bacteria that is there. The antibiotics that you probably want to use, say in a community acquired pneumonia, should be what? let's say community acquired. In catheter urinary tract infection, there is nothing. You will have to deal with one of those difficult bacteria. Okay, you'll have to deal with one of those difficult bacteria because of the fact that this is catheter urinary tract infection, a hospital acquired infection. So even if you get an E. coli, that E. coli may be very resistant to organisms. It may be very difficult. It may be difficult to treat. All those things would be there. Okay, so there the local antibiogram will come in place. We'll come to that. How you decide on whether this is a CRE or not CRE, that is a big distinction. But in community acquired urinary tract infection, classically you would like to give a very simple antibiotic. Like if it's in the hospital, you're talking about the patients who are at home. At home, you're probably not worried on you because they are okay. Yes, cystitis. It's not really just a small fever, nothing more than that would be there. It's just a cystitis. On its own also it may become okay and a Septran will probably work. A Septran DS will probably work when it's at home. You don't require any hi-fi antibiotics. But when the patient is so sick that the patient comes to the hospital, then the community acquired urosepsis is definitely something you want to treat with an IV antibiotic. You understand? If the patient has come home, he has come to the hospital, obviously he is sicker than otherwise, right? That is why he has come to the hospital and you have advised an division. That's how sick he is. Not in the ICU but in the ward. What do you give these patients? What is your first antibiotic you give? So first of all, how do you judge that antibiotic? How do you judge? The antibiotic should be effective against most important. That is the first thing you think. The first thing I think is my antibiotic should be against the E. coli. Number one, gram negative. What is the second thing? There is another gram negative also because he is very sick. Maybe Pseudomonas also there. So I must think of Pseudomonas also. Okay, if he is very sick enough to get admitted, right? What is the third thing I must think? This antibiotic should get concentrated in the urinary tract. I must think like this also. That this antibiotic should be in the urinary tract, means excreted through the kidney. If it is excreted through the kidney, it is going to do very well. Right? So which are those antibiotics? Simple antibiotics like piperacillin tazobactam. Okay. Second antibiotic would be ceftazidime. Cefepime, that is cefepime. And the third thing is meropenem. Because he is sick enough to come to the hospital. So 3 antibiotics. Now piperacillin tazobactam strength. The strength is that it gets very easily gets into the urine. It covers everything ESBL, the simple ESBLs. It covers the AMCs. So that's where we'll come to that now. And what is the strength of cefepime tazobactam? Same thing. It covers mostly the AMCs, but it evades some of the ESBLs. It cannot get the ESBLs in place. That's a weakness of cefepime. Whereas meropenem gets through all this, but meropenem is an overkill many of the times. You don't want to give meropenem because we know that you may be able to escape with this. What about ceftriaxone? It's a good antibiotic, no doubt it's a good antibiotic. However, the excretion is not through the kidneys, the excretion is through the liver. So it may not achieve great amount of concentration in the urinary tract, but you can still give it in a patient clinically. So nothing is black or white in management of urinary tract infections with respect to antibiotics. It all depends on what you feel is the right antibiotic at that particular moment, the culture and the local antibiotic platter that you can probably get. In CAUTI, moreover, all the more reason to believe in CAUTI what is to be done, because you need to know what is happening in your ICU to understand CAUTI. Clear? How do you prevent a CAUTI? How do you prevent? Now that we know that CAUTI causes morbidity, causes mortality, we've understood a little bit of the management, the diagnosis and the definitions. How do you prevent a CAUTI? The answer is always prevention, right? If you prevent, all the problems will come down. So to prevent a CAUTI, what you will do, Arshad?
Hygiene.
Sorry?
Hygiene.
So what does that mean?
बावल अपना ब्लैडर के टाइम पे थोड़ा सा ध्यान रखना.
What do you mean by that? What do you say? What you said hygiene. What is hygiene is a very broad terminology. What are you going to do? So how do you think that you can prevent a CAUTI? Nikhil, so how does that? What is all that?
As mentioned, we have to clean the catheter with soap water.
First thing that comes to your mind should be what?
Hand
hygiene. The first thing that comes to your mind whenever you talk about aseptic precautions in anything, let it be CLAPSI, let it be CAUTI, let it be VAP, let it be anything, should be
Hand hygiene.
that should be the first thing coming in your mind. Hand hygiene. Okay, strict hand hygiene. This comes first during insertion and maintenance of the catheter. Strict hand hygiene during insertion and maintenance of the catheter. That is the first thing. So that is during insertion. Obviously, strict aseptic precautions come to place. Strict aseptic precautions. Then second thing.
Barrier precaution.
Hmm?
Barrier.
No.
So can we say like avoid as far as possible?
Avoid, yeah. So as far as possible, avoid a catheter, or for that matter, attempt to remove the catheter as quickly as possible. Avoid to insert a catheter or try to remove the catheter as quickly as possible. By the end of this talk, we realize that every single day you are adding on a colonizer. We know that. Every single day we are adding on a colonizer, right? So 1 to 3% colonization rate per day. Okay, so every single day you are adding a colonization. Understand? So as quickly as possible, take the catheter out. Then, third thing, where should be the system be?
Below the
Yeah,
pelvis.
ensure that the system is below the pelvis, not touching the floor. And importantly, when it is getting full, it has to be drained by separate containers. When it is getting full, it has to be drained by separate containers. For example, when the Maushi comes to empty the bag, you see an empty bag, empty karo, it has to be done by a separate container. She cannot go from place to place with the same container. They are not knowledgeable enough. You are knowledgeable enough. So in the morning when you see them doing that, you should stop them and say, दूसरा container लो, दूसरा container लो. समझ में आ रहा है? हाँ? So every bed has got its own specific container. They have to use it only with that specific container. Clear? Clear on this? There is no role of prophylactic antibiotics, there is no role of antibiotic instillation into the bladder, and there is no role of antibiotic instilled into the bag. There is no role. There is no role of any of these things. Prophylactic antibiotics, antibiotic instillation into the urinary bladder, or antibiotic inside the bag. There is no role of any of these things. Clear? Clear on this? So this is the prevention of CAUTI. This is exactly the prevention of CAUTI. Any questions on this?
So those you mentioned about the catheters. Few were alloy.
Yeah. So does that work? So there is no clear-cut evidence-based recommendation that says that the silver alloy catheter or a silver impregnated catheter is to be done as a routine. But in patients who've got recurrent urinary tract infections, who have got higher incidence of urinary tract infections, you may want to give silver alloy catheter on top of the silver impregnated or the normal Foley's catheter because it prevents asymptomatic bacteriuria. Asymptomatic bacteriuria. This is what we know. Okay, so it is a little bit beneficial if you ask me because it prevents asymptomatic. But does it do anything to CAUTI or length of stay or mortality? No, it doesn't. So if I have a patient who comes with repeated urinary tract infections, okay, he's been at home dwelling person, sitting at home with a catheter or spinal cord injured patient who's got a catheter in place. Maybe I might say, you put in a silver alloy catheter and not a silver impregnated, not silver impregnated, silver alloy catheter. I would probably use in these cases because there is some benefit. Similarly, there is a benefit of having hydrophilic catheters versus Foley's catheter again in what? Asymptomatic bacteriuria. It's not very clear whether it really makes a difference in catheter-associated urinary tract infections, which is a completely different thing, where the patient has got symptoms and is sick. Clear?
So something you mentioned regarding demented patients.
So patients who are demented, so it's very difficult, no? So now you imagine you have a patient in the ICU. You have a patient in the ICU. That patient is demented. Whether does not see any signs or symptoms, so you can't get even suprapubic tenderness also you can't get because he's demented. He doesn't really respond to anything. Okay, and now you want to diagnose this as catheter-associated urinary tract infection. It is so difficult now because now you must understand that this will be colonized. You send a culture, it will be positive. Are you understanding? Sachin, are you understanding? It is going to be positive. He is not going to give you signs and symptoms. How are you going to say that there is catheter-associated urinary tract infection? So the evidence is not very clear of how to diagnose these patients. That is why your clinical knowledge makes a very big difference. Otherwise ChatGPT would be treating all our patients. You understand? If it was so simple, ChatGPT would be treating most of. That's why clinical knowledge is what you require. Your clinical knowledge is so important that you are doing your ultrasound. At the end of the day, you might feel tomorrow, 10 years from now, artificial intelligence will take over everything. It is not going to take over because there is lot of other things that are going to come in place when you are doing it. That's why as time goes, you should get your clinical knowledge more important. Clinical knowledge, because that is the only thing that is going to hold us against the machines. So if you have a dementia patient, what am I going to do? I'm going to look at this patient, I'm going to look at what his trajectory was, I'm going to look at whether he's got a respiratory tract infection, whether I can do an ultrasound to figure out what is there, a good auscultation to figure out whether I'm seeing something over there, an abdominal examination to see whether there is abdominal pain away from the suprapubic area, and then considering why he has come here, what is the reason for it, and then rule out everything else, and then think of the catheter as a urinary tract infection. So in a dementia patient, it becomes even more difficult to actually figure out catheter as a urinary tract infection. So if this patient is at home and having repeated UTIs in the past, what will I do? I'll put one of these catheters. You understand? I'll put one of these catheters that will at least prevent asymptomatic bacteriuria, which will actually reduce asymptomatic bacteriuria. You understand? So it is a very difficult diagnosis, not so simple diagnosis. So by now you will understand that when you send a urine culture, when you send a urine routine, and how you look at a urine routine. Clear?
So regarding sending urine routine, like even if I mean to say, if before sending, like if we order for send blood culture, so looking at the cost, can we go for urine routine first and then we can think
For what?
if like we are trying to diagnose any source of infection?
Any source name, source name. This is the wrong statement that you're making. You never think like this. I want to search for a source. I am going to clinically identify my source and then send that particular representative culture. You're understanding? You never search for a source by sending investigations. Never do that. Patient comes in, चलो urine भेजो, VAC का भेजो, blood culture भेज दो, skin soft tissue का culture भेजो, CSF भेज दो. Never. So when a patient comes in with an adequate history, judicious examination, you should first figure out where is my source. Above diaphragm, below diaphragm. If it's below diaphragm, where below diaphragm? Is it the liver? Is it the kidney? Is it the abdomen? Is it the urinary tract? This is how you're going to think. Based on that, I'm going to take a call what I'm going to send. You're understanding? There is nothing like I'm going to send all pan cultures. That is wrong. That is absolutely wrong. Absolutely wrong. You never do that. So if a patient comes with a catheter from outside and I want to diagnose catheter as a urinary tract infection, no, I'll remove the catheter, pass in a new catheter in the first place. If I'm suspecting it, I'll just take it out and pass a new one, and then I'll search for other sources because I know if I send a urine culture, it's going to be positive. You understanding? So always when a patient comes in, look at the system involved. कौन सा system involved है? उसका पहले तुम diagnosis मारो. Narrow down your diagnosis to which system I'm looking at. When I look at that system, then I will send representative cultures. Like for example, yesterday's patient. Yesterday patient came in, was having hypotension, was having a respiratory rate that was elevated, and I came to the bedside of that particular patient there. Okay, what did I do? I auscultated. I found out there is something in the chest. It's very bad. There is something in the chest. This is looking like something that is there coming from here. Where is the source of infection? Is it the urine? Is it I pressed the abdomen? I didn't get that kind of pain that I actually thought. So what did I do? I think the infection is in the lung. Okay, and that lung infection has probably become septicemic, and that's why there is low blood pressure. So let me put this patient on. Let me do a culture from the lung, and that is why I sent a culture from the ET culture. You are understanding? Now in that patient, if I would have done fan culture, if I would have gone ahead, then urine, then blood, then CSF, then everything else, I would get something somewhere. And then what do I do? Where is my source of infection? What is the X-ray showing? देखा नहीं मैंने X-ray.
Actually, there is some right side थोड़ा सा.
Right side.
Clear? So any doubts on this till now? You got your answer?
Hello. Yes sir.
Any doubts?
Sir is taking lecture.
Any doubts over here? No, na? ठीक है? So let's finish one more topic.